Welcome everyone to today's webinar, From Change Healthcare to Crowdstrike, Managing Systemic Risk to Prevent the Unthinkable, sponsored by Sensinet. I'm Naomi Diaz with Becker's Healthcare. Before we begin, I'm going to walk through a few quick housekeeping instructions. We'll start today's webinar with a presentation, and there will be time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. To access the recording, use the same link you used to log into today's webinar. Additionally, the slide deck will be available upon request for attendees. Don't forget to check out our resources section for additional information and fill out our session survey. Both can be found on the right side of your screen. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. With that, I am joined today by Ed Gaudet, CEO and founder of Sensinet, David Waska, CISO at Sensinet, John Riggi, National Advisor for Cybersecurity and Risk at the American Hospital Association, Eric Decker, VP and CISO at Intermountain Health, and Jagar Kadkia, CISO at Emory Health. Thank you both so much for being here. At this time, I'll now turn over the floor to Ed to kick off our discussion.
All right, thank you. And John was giving me the business earlier, Eric, about my photo. He said it was false advertising, so we'll have to update that. All right, we got a lot to cover today, so I'm excited. This is such a timely issue and topic, and so we're going to get right into it. So what is systemic risk? So when we think about what's been happening over the last couple of months in particular, what do you make of this, folks? Let's start with John.
It's pretty significant. When you have these third parties, basically third-party service providers, third-party technology providers, and third-party supply chain get attacked by these primarily Russian-based, Russian-speaking ransomware groups, to me it says that the bad guys have shifted from not only targeting individual hospitals or health systems, but moving towards attacks which have systemic impact. The broader the impact, the greater the disruption, and quite frankly, the higher the ransom they can charge. And I think the way healthcare has evolved with our interconnectivity between services, systems, layers and layers of applications are creating this type of systemic risk, but also the concentration of services and technology as we had in Change Healthcare. So through a number of mergers and acquisition, there was a consolidation of mission critical services, which created concentrated risk for the entire healthcare sector. And the bad guys understand this. So they're targeting these organizations, these technology that provide access across the sector, and that can also represent a single point of failure to cause disruption on a sector-wide systemic basis.
Excellent. And Eric, from an industry perspective, what are folks doing today at federal level to deal with these recent occurrences of systemic risk?
So there's a few activities that have been stood up through the Health Sector Coordinating Council Cybersecurity Working Group. There was a sprint a few months ago on mapping out some specific critical functions. So when you think about what a critical function of how a transaction flows through the healthcare ecosystem. So let's just take retail pharmacy as an example. When a patient goes to a doctor and that doctor orders a prescription that's delivered to a pharmacy, there's a whole connection that flows, through an ecosystem that includes not only the direct patient care provider, the third parties that are making the connections, the exchanges and so forth that it goes to, the pharmacies that are receiving the orders, the PBMs that are looking up at the formularies and the copays and authorizing whether or not you're permitted to get that pharmaceutical order, and the health plan at the back end that's ultimately figuring out how the claim is submitted and remitted and so forth. So every single transaction that exists, and that's just one critical function. That's one piece of delivering pharmaceuticals, delivering a drug to a patient who needs that as part of an order submitted by their provider. If at any point, as you look through that transaction, you start to see, as John was talking about, convergence happening in the market, then that's a place of fault, of convergence risk, and it's a choke point. And just because there's a choke point doesn't necessarily mean it's bad, because in any system, there's always going to be a choke point. There's always some place where, as the widgets are on the line and getting processed from raw materials into final product, it converges into one place where that has to be optimized. So the issue,
I think thinking about it from the choke point perspective is a good one, Eric. Why is this happening now? Why all of a sudden is this happening, over the last six to 8 months?
Well, I mean, I think John sort of hit the nail on the head here. I mean, as the markets have converged and these choke points have become more pronounced and understandable, the materiality of that choke point has ramped up. So whereas before, if you have a choke point, you only have like a 20% of market share inside that choke point, maybe you've got 20, 30 different companies that are doing this, that's not going to cause as much damage if that goes down. If you have one company or 2 or 3 companies that's inside that choke point and it's material to your organization, then you've upped the game on the impact associated to that, and that has become a more pronounced target with causing more disruption.
Great points. Jigar, would you like to add anything to that? And also, what are you seeing on the ground? What are you doing differently to deal with systemic risk at Emory?
So, I think John and Eric covered it pretty concisely. So there is a consolidation of the major vendors out in the landscape. I think what change and other incidents have, I think, made people more aware is how interconnected and interdependent we are on each other and our third parties and fourth parties in the ecosystem. So we're all very interconnected. But more importantly, I think it's raised the issue of enhancing or re-examining our overall resilience to system outages, right? So change clearly brought on a view in the revenue cycle and reimbursement type area to reevaluate not only the vendors we're using, but what are our continuity plans and our resiliency plans. So something like this will probably happen again. Are we going to be better prepared to address that? As well as looking at other parts in our internal environment to identify areas that are critical to business operations and, re-examining the continuity plan, re-examining how we can create more resiliency and focusing more efforts around those areas so that we can mitigate any type of issue that potentially is going to come, whether it comes tomorrow, next month, or next year.
Excellent. And I know Eric published an article with a few other folks recently. Harvard Business Review covered this topic in some really good detail. Highly recommend folks go out there and read it. But as we look at this and we think about those nodes getting bigger and bigger, there's 2 vectors. One is market consolidation forces, but there's also the forces internally to consolidate for economic reasons and resource reasons. How do we reconcile that with systemic risk, and how do we balance the right level of consolidation with the right level of risk mitigation? And maybe I'll turn to John, because you've got this purview across the sector with hospitals.
I think it starts with a mindset for the organizations, really treating cybersecurity as a risk issue primarily, and truly understanding that when you do have this consolidation or reliance on technology, try to understand what the impact would be if that technology failed. And even at the purchase, acquisition, the research phase of the types of technologies you're bringing into the organization, thinking about what is the built-in redundancy and resiliency that comes with this technology? Are we demanding that the technology developers, the software developers, utilize secure by design principles and then help us shape market forces and demand as well? But really for the organization to really understand, if we lose this mission critical or life critical technology, what are the cascading effects, if it can be mapped or predicted even, and then understanding what are our downtime procedures, in essence, our resiliency capability to maintain a loss of that technology or service or supply chain for 30 days or longer. Because again, it may be an issue where your healthcare organization is not attacked directly, but you have the third party like Change, like Crowdstrike, like OneBlood, the blood supply, they're attacked, but you still have to deal with the impact. So understanding not only your internal resiliency, if your systems go down, what is the resiliency for loss of these third-party mission-critical services providers?
It's a great point, and the tie into cybersecurity is an obvious one, but CrowdStrike was not really a cybersecurity event. Dave, how can CISOs and IT leaders start to think about systemic risk more broadly? What are some of the considerations there?
So I think you need to think of let's use CrowdStrike as an example. So in that particular case, it was an issue with a library that got loaded. So it's all about demanding of your software vendors to have, you use the words, John, secure by design, right? Have the right processes in place so that there are checks and double checks before software is ever delivered. We're a software company here at Sensinet. So, we always make sure that we have good processes in place before software gets delivered. It's the same thing for medical device manufacturers or other equipment, OT, IT. You need to make sure that your vendors have the best processes possible in place, and you need to be assessing them on a regular basis to make sure that they're implementing those good security controls.
And Jigar, what was your experience with CrowdStrike? How did you manage through that? Did it affect you at all? And what were some of the learnings you took away?
So it absolutely impacted us. We had thousands of workstations across our enterprise impacted by the issue. Everyone had to do the same thing. Either they used the thumb drive or they had some other special flavor. But at the end of the day, you had to touch every machine that was impacted and to fix it. So that was a bit eye-opening, right? Especially in this multi-hybrid work environment where there aren't a lot of technical people always around. So that was one kind of barrier that we were able to overcome. The other thing, which I think is a bit of a silver lining in this, is we did touch every device in the environment, right? So there were devices that were stale, probably had never been updated, et cetera. This allowed all these devices to be updated and quite frankly it gave us a new view into the asset inventory of our ecosystem. I say it made people more aware of how critical the electronic devices, the endpoints are in our environment, right? We are similar to the iPhone. Computers are a crutch for us, and everyone has an iPhone, and it's a crutch, right? Think about, you leave your house and you forget your phone, you get very frustrated. No different than in the hospital. If they can't use the computer, they get very frustrated because they can't, properly treat their patients.
Yeah, how about you, Eric?
Well, we were not impacted by CrowdStrike, not a CrowdStrike customer. So, but that doesn't mean that we haven't experienced moments like that before with other technologies. So I think the big thing about CrowdStrike and other systems that have gone down like this, not from a cyber attack, but from a technology disruption, is this is inevitable. Inevitably technology is going to fail, and technology is going to cause a business disruption. And so this idea that we're going to prevent it all, I mean, obviously we want to control that as much as we possibly can. We don't want these disruptions to cause these outages, but technology fails. And so you have to have a resilience, plan, an incident response plan to account for both the technology failure as well as the cyber failure. And I think that's what CrowdStrike showed us it was a worldwide global response of how everybody did exactly what Jigger, had to do, who was a customer. And for the most part, a lot of people actually got back up within 24 to 48 hours, which is kind of good news, because it shows that is a level of resilience. It sucks in the moment, for sure, but the damage was not prolonged into weeks and months like some of these, massive attacks that we've seen, which actually is what causes the really pronounced damages when that happens.
Like MOVEit. Right. It seems like this is the attack that keeps on giving. What did we learn? What did we learn from this, John?
Oh yeah, thanks. So, but I think what also points out, obviously, as Eric was indicating, the need to be resilient for whatever the cause is, whatever the loss of technology is, but really how fragile our digital ecosystem is. No one could have predicted that 40K line of code, 40 kilobyte code, would have interacted in such a way with Microsoft to cause the blue screen of death on 8.5 million computers around the world. And I'm getting calls, messages at 4:30 a.m. on that Friday from hospitals saying, John, we are on ambulance diversion, and our diversion point is also on ambulance diversion. So real world, short-term, high acuity impact that potentially caused a risk to patient safety as well, or planes being grounded. So we just have to think about how this complexity that we're adding, digital complexity, is creating risk that, and maybe we won't even be able to predict it in certain ways. But the bottom line is to develop those resiliency procedures for whatever the cause, whatever the disruption might be.
Yeah, I add to that?
Yeah, absolutely.
What I wanted like to say is I think we need to stop thinking about this in the terms of, prevent it from happening. The double impact of diversion and such like that John just said is very damaging. There's secondary, tertiary, quaternary impacts on these things. It's not about, when it comes to material issues, life safety issues, we need to be thinking about this in terms of how do we maintain our operations without our digital systems with the minimal amount of decompression. That actually requires your clinical operations, your emergency operations folks to be drilling this, to where you have a goal that you're setting, maybe a 5%, decompression rate in the ED. And then the organization has to figure out, how do you hit that when it's all gone, when all the technology is not there? The reason why these things are so impactful is we've become so reliant on it. We don't believe that the rug can be pulled out from underneath us, and it absolutely can be pulled out from underneath us.
And I just want to add, one of the things that we're promoting to the field is that think not only in terms of business continuity. When non-technical leaders hear that, they think that's an IT issue primarily, business continuity. We say, think in terms of clinical continuity. If all the technology that you depend on, network and internet technology, is suddenly unavailable, how will you continue to care for patients? And that is primarily a clinical issue. Develop those policies and procedures for clinical continuity.
Mm-hmm. Excellent. Jigar, you look like you want to say something.
I think it just goes back to the original point of, we have to have better resiliency overall, and we need to really focus in on the core operations at the hospital, regardless. And if you look at the way we have evolved in the hospital world, a lot of physicians today, they are trained on iPads and electronic devices and the EHR, et cetera. And there are very few people that are skilled enough to be able to do the types of things that people are doing today on paper for a prolonged period of time. Everyone has downtime procedures. They can probably get away with it for 12 to 24 hours. But once you get past 24 hours, it really becomes a crippling impact on the system itself, because very few people know how to do paper records and properly document and manually do medications, et cetera. That's a skill that today's world doesn't really have to learn that much. And that's a unique skill that is hard to find. And, the longer these types of incidents occur, the more impactful that becomes and the more impact there is on patient care.
Excellent. Let's wrap up this section before we move on to the next. What advice do you have to CISOs and other IT leaders that are really trying to get their arms around this topic, systemic risk, and present it in a way that covers all these drivers on the screen so that their board can understand and really help them with resources and other investments? I know it's a mouthful. Eric, you want to go first?
I was waiting for you to figure out who's going to take it. So I think the first things first, there's a few things, I think everybody that exists inside the ecosystem needs to be doing the basics, and it's not just the hospitals, it's the people we connect to, it's the third parties, but it's also the other people in healthcare, in the healthcare industry. The ecosystem of healthcare is more than direct patient care. Plans and payers, it's medical technology manufacturers, it's pharmaceuticals, it's health IT, and we're all interconnected. So that's one. Two, we need to recognize that not only are we consuming risk from the people we are connected to, we induce it to the others. We think of ourselves as the center of the universe. We're not the center of the universe. We are a node in a connected ecosystem. And so if that ecosystem isn't living and breathing and signaling and working with each other, then when it fails, it starts to cascade and fail through the ecosystem. So we gotta shift our mindset. I actually don't even like the term anymore, third and fourth and fifth party risk, because it implies that my obligation ends after the third party. And yet, as the first thing I described was like, just look at pharmacy, and ordering of a drug. And as it flows through the ecosystem, I can be aware of that. And I can be aware of where the convergence is happening and what are we doing about that convergence. So I think that's another piece. Fourth, your organization needs to understand what a material relationship is for your organization. It will be different for everybody. Not everybody was impacted by Change Healthcare. It was very damaging to the whole of the ecosystem. Some way more critical than others. And so the big wake up moment for me with Change was, how did we, as 20 years of third party risk management, best practice, et cetera, how did we not uncover that it was this important, that there was this material, that it was that critical? And in fact, I fully believe that if you have a material relationship, and you need to find that based on the highest level of impact, and actually, I think you can follow a little bit of the SEC guidelines on this, even if you're not a publicly traded organization, you can still use that mentality. If it's a material relationship, then you should not be looking at this as likelihood of that thing going down, because we are terrible at determining likelihood. And instead, it should be, how bad will it be, and how resilient are we to when it is hit. And that should be your risk equation, and that should drive how you actually build resilience into the organization. So focus in on what's material to you, focus in on that, and build your continuity plans and go forward.
Love that. Jigar.
Yeah, so I think along the same lines as Eric, we have to work with our business leaders and identify the critical workflows that impact us, and do follow the chain all the way till the end, right? So, pick one process. It's probably supported by one or two or three vendors, both internal purchased items as well as external vendors. Follow it to them. Talk with them, work with them to identify what else they're using, and follow the chain so you can at least have visibility to all the components in the chain, and maybe do some level of evaluation. So if something breaks down in the chain, whether it's first party, second party, third party, fourth party, fifth party, then you have some level of Maybe you have a resiliency plan for that. Maybe it doesn't impact you as much, but at least you have visibility into the entire chain. And then you can make an informed decision on investment, what you want to do from an organizational standpoint, how you want to have a conversation with them, et cetera, so that you can really focus in on those critical. I'm guessing you're only going to be able to pick maybe 5 to 8 to do this level of detail, but this is the type of detail we need to get to for each one of these critical people in the ecosystem.
Excellent. Let's pivot to doing the hard work. Let's talk about what that looks like. We've covered a little bit of this already, but John, any comments about the overall lessons learned from a macro perspective? What have you heard from CEOs, not only the IT leaders, but also CEOs from a lesson learned perspective?
Well, I think, again, the first lesson learned is that we were unaware, as sophisticated as we are as a sector, the collective intelligence that we have, we weren't aware how dependent we were on Change Healthcare and or Crowdstrike. And it was unpredictable what the cascading effects were. So I think we've learned that to ask the harder questions when we take on new technology. The AHA, as you all may be aware, we opposed the merger of United Health Group and Change Healthcare and Optum, more for business reasons, for monopolistic reasons. But now DOJ and the FTC are looking at cyber. If you have that concentration of services, does it create undue cyber risk? But again, understanding what the impact, the material impact would be to life critical, first, mission critical operations, and then really developing these procedures. The other thing that came out with Change and the blood supply attack, that there were exclusivity clauses in their contracts that I believe prevented hospitals from properly preparing for the loss of Change Healthcare or loss of blood supply. So we should, as organizations, try to avoid any exclusivity clauses for life-critical or mission-critical services that would prevent the preparation of resiliency plans, prevent contracting with alternate sources of supply, alternate capacity, should that mission-critical service go down. So really taking a very critical look, engaging mission-critical thinking, critical thinking and strategic thinking about who we are engaging and have these material relationships with.
Yeah, and as Eric pointed out, follow it all the way through to the end to really understand the transaction, which I think is a really good advice to folks. So as we dig deeper into sort of the lessons learned and what to do moving forward, we've spent the last 4 years really dealing with these attacks, shutting down not just IT, but shutting down clinical operations, as John said earlier. Are we able to sort of pop the stack and simplify what's happening here, Eric? Is it really that is it becoming that? Is there an Occam's razor here to simplify this for folks?
Yeah, the slides you're showing right now, actually. and I don't. I mean, so first of all, if you're an analyst, like a SOC analyst or a threat hunter or somebody on this call, you're probably looking at this going, "That's ridiculous. This is not that simple." So this is a model, and it's a model of how to think, and that's really ultimately what it entails. And one of the things that, and this was sourced from a landscape analysis effort that Sentinel, AHA, and the Cybersecurity Working Group, which they're all members of that, and Health and Human Services and CISA helped put together on studying how hospitals are getting beat. That landscape analysis was released from HHS last year in April. You can go up to HHS's site and just type in landscape analysis, you'll find it. And what we did was we looked at, how does the industry think that it is resistant to cyber attack, the disruptive cyber attacks that cause prolonged outages, and how are we getting beat? How is it actually happening? And so far, I am still batting 1,000 on this. There was one moment I was off, I was almost off, but it turned out I was still batting 1,000. The way that you got to think about this as the adversary. So how is organized crime, which is the one who's doing these kinds of attacks, they're motivated to causing ransom and extortion types of deals. They are breaking it through social engineering, of course, nothing surprising there. but it is beyond the fish now. It is into MFA re-enrollment attacks at the service desk. If at the service desk you use the last 4 digits of their social security number and date of birth as the identifier to prove out who you are, you will be compromised, because that is all compromised. You know, it's out there in the dark web. It's out there and accessible. So it's MFA enrollment, it's MFA fatigue attacks, it's, you know, things along those lines where you're bypassing that second factor that we've all put in play. Third-party compromise is not the data per se that what our third parties have, but how those third parties are connected to you. And that connection could be incredibly risky. This is the Target attack from almost a decade ago now, you know, where a building management system, you know, broke in and got into the POS system at Target. And that was like the first iterations of that. And then the third is you have a vulnerability exposed to the internet directly. And that's in your cloud or in your on-prem. And that could be a known exploited vulnerability that's on the CISOs KEV list. If you have a vulnerability that's on the KEV that's on the internet, you better be fixing it within 24 to 48 hours, because bad actors are leveraging it. It could also be a major mistake, like no two-factor authentication on a portal system. As we now know, that was Change Healthcare. It was the social and the lack of two-factor. But that's the beachhead. That does not cause ransomware to go everywhere. Every attack ends at privilege escalation and ends at getting to the same level of control that the IT people have. The attack goes to IT, and it manifests itself in Active Directory, because that's where, generally speaking, we run and manage all of our assets, the privileges that exist inside AD. And that's more than domain admin rights for those of you who are technical on this call. There's like 89 some principles in AD that control your environment. So if you're not controlling that, and you're not breaking the chain by which the IT people manage those assets, the bad guys are just going to follow the same path. They're just going to find the IT person, break the IT person, get their creds, go in and do what they need to do. So thinking like an adversary is thinking, how do you stop the front end of this, and how do you stop the back end of this? Everybody talks about how these attacks are sophisticated. My interpretation of this is the attack itself, the methods, the TTPs that are used are not sophisticated. What's sophisticated is the scale and the operation by which the bad actors operate. They can do this at massive scale. They've scripted it, they've automated it, they can get in, they can figure out all the little nuances, they can subvert your EDR, they can do all these things and roll through this pathway right here to cause the damage that they cause. So we got to be thinking, how do you stop it? How do you disrupt it? Because you disrupt their ability to scale. Now you've made them go to a manual process, and you'll slow them down entirely.
Yeah, agreed, Ed. If I could just add in there, when we had a lot of discussion and debate back when we were doing this, agreed. We were saying it's not the intent of the landscape analysis is not to pick a winning framework. It's to understand how we're being beat from the mindset of the adversary, as Eric said. A lot of history chasing bad guys. We have to understand how they're coming in, what their mindset is, their strategy, and ultimately look for those indicators as well. So as their tactics change this year, we're going to do landscape version 2.0. Has their methodology changed? Every threat intelligence bulletin issued by the government, when I was at the FBI, we would list, these are their TTPs. This is what you can do to mitigate, helping folks understand that. And then ultimately, for instance, I see constantly cobalt is used. So the cobalt blue exploitation, living off the land. Should we be tracking for activations, alerting on activations of that exploit, of that legitimate third-party tool? We know they're constantly using Active Directory, as you said. But agree with Eric 100%, and that's the direction we have to move forward, and we'll continue to advocate to take this approach.
So this is FBI and the AHA approved. Jigar, is it Emory approved? Has he missed
Absolutely. Emory approved. I think the biggest thing here to really focus in on for most of our organizations is identity. We are using a cobbled together group of systems. Many of these systems are very old, technology challenged, and we're trying to manage large numbers of identities at varying levels of privilege, including administrative level and super user access, et cetera, with very, very, I don't want to call them brittle, but brittle tools and tool sets that are fairly unsophisticated, in that everyone wants to access systems with the least amount of resistance for the ease. And there is a focus on trying to free up access to make it easier, less cumbersome for our clinicians, nurses, researchers to access systems to do the very, very important life-saving work. And so there's a bit of a compromise associated with that. The level of sophistication, once the hackers are in, is very sophisticated, as Eric alluded to. They're using automated scripts. They're using all kinds of tactics and techniques that we most likely cannot detect with any of our legacy tool sets. And then the advent or the prevalence of AI into this equation is only going to ratchet up our need to improve the way we do identity, the way we manage identity, and the way we protect our identity. And so at the end of the day, everything revolves around identity, and we are in we're in a battle, and we're behind right now, and we got to catch up.
Yeah, I'm going to give Eric 2 minutes to comment on identity, because I know you can spend 4 hours talking about it. Advice to your peers, advice to other CISOs.
So here's what I say. It's what I tell my team, and it's what I tell a lot of people. The challenge in cybersecurity is a focus problem. There are risks everywhere, and if you look, if you look for scary things, you'll find scary things, and so you've got to frame your reference into what I think as the probable versus the possible. This is just a general framework that I give people. The possible means that you can what if your way into that thing occurring. If it's possible, that means it's probably not going to happen urgently. It's not that it won't happen. It's just that, you can put that into a separate bucket. You can put that maybe into the important bucket. If it's probable, which means that this is how the attackers are doing their work, they're breaking into MFA, they're using identity, verification techniques, they're doing all this stuff. If it falls within the guardrails of what you just saw before, the 3 ways in, one thing they're doing once they're in, then you need to be doing everything you possibly can do to put the brakes into stopping them from doing what they're doing. So this, when we talk about like friction as an example, user experience and friction, part of our job is we're trying to navigate that balance. At what point do we say, no, you got to jump through a hoop, clinician, to do the thing you need to do, versus you don't have to jump through a hoop. Knowing that the attacks run to, they attack everybody in the organization, beachhead, then into IT. So there's some very, very basic things that everybody should be doing. Multi-factor authentication. We should never be discussing this anymore as should we be doing it? Should we not be doing it? We need to be doing it. It's the only way to stop the credential attack. There are so many. Your credential is stolen. I'm sorry, it's gone. So there's no way. You cannot rely on that as a secure means. So that's basics. Blocking and tackling, hygiene kinds of things. But when it comes down to like the control of the environment, you should be putting all kinds of barriers in place for how IT controls the environment. They should not be doing it from the same computer, from the same account that they use as their normal productivity. They should be using different things, different computers, and you should be restricting and securing that by design inside your system so that they can't jump through the hoops. Because you put a pathway in that allows you to jump in, the bad actor will do the exact same thing. So, you got to build that resilience right into the structure.
Excellent points. We have a lot of questions coming in. So we talked a little bit already about this slide. We covered the 5 actions already, I believe. So you mentioned hygiene, and there's a question around CPGs. What's the latest status? What's the state of the CPGs becoming law, basically? Eric, do you want to start there? We'll go to John.
Yeah, I can start. So when we built the CPGs, this was a partnership with HHS, CISA, and the White House, actually, the Office of National Security, Cybersecurity Director, and the National Security, the NSC. The idea behind this was resilience. Like, what's the puzzle piece missing from the current regulatory regime and other things towards like stopping the disruptive attacks that are occurring? And so the essentials were really focused on like the absolute basics, and then enhanced was like sort of the next step. These are all voluntary as they were released, and you'll see from the previous slide that on the HBR article, if everybody's not doing this, then the weakest link in the system breaks down, and then it breaks, at the end of the day. So starting with the essentials is sort of how the current proposal was put forth, which was build incentives into the process in order to direct financial incentives, especially for the needs-based organizations. You think about the rural hospitals, the critical access hospitals, the community hospitals that are operating in the red. Putting a mandate down on them might be the thing that actually breaks them. And we don't want to do that. This is a public health kind of situation. So we need a ramp up period. Think meaningful use for cyber, where people can adopt, they can get incentivized to adopt, they can get stimulus monies to adopt these various things. And not all of this actually requires technology. Some of this just requires people and process. So that was the proposal that was made for the 2025 budget, was a two-year ramp up period for the essentials, then followed by a sliding scale 2-year ramp up period for enhanced, and it was something like $1.8 billion that was allocated towards stimulating the organizations to adopt this. And then the disincentive side of that was market basket increase removal. So you don't get, it's inflation essentially. So you don't get the consumer price index increase if you haven't adopted it. So that was the proposal. Now the method that they were going to attach this to, there hasn't been a lot of updates on this recently, was reopening up HIPAA under the HIPAA security rule. That was produced as a notice that was submitted earlier this year. And I think that they're still in the process of doing that, but I haven't heard recently on what the current state of that is.
All right, John?
So obviously we worked, the AHA, myself worked with Eric and the team there to help develop these practices. We 100% support these practices as voluntary, best practices, common sense, right, for all of that, for these 10 essential, 10 enhanced. The issues we have, as Eric mentioned, is that if these were imposed upon hospitals alone, and hospitals which are unable due to a lack of resources to meet these, and then you have severe penalties. These and that they would be enforced through conditions of participations, meaning reduction in Medicaid and Medicare reimbursements. You'd be hurting those hospitals which actually need the most help if that regime followed through. So as of last week, I happened to speak at the Modern Healthcare Symposium in DC. John Blum, Chief Operating Officer of CMS, was there also that morning. He indicated that these 10 essential, 10 enhanced CPGs may become regulation in the near term, but they would apply to all entities in healthcare. And that's what the AHA is advocating for, that if they come forward, they should apply to every entity in healthcare. They should be accompanied by resources, although the president's budget's hung up. And then ultimately, the penalties must be considered. It must be done in a way, if there are penalties, that does not harm those that most need help. The AHA and the White House, the NSC, we weren't waiting for government funding. We went forward and began working with Microsoft and Google to ask for the same nonprofit pricing that state and local government and academia are receiving, and ask for that for hospitals in need, that with demonstrated need. And they said yes. So we're helping with, again, creative solutions coming forward to help fill the resource gap for the hospital field.
Excellent. And speaking of creative solutions, Dave, how can an organization see where they are regarding the CPGs and their overall compliance and coverage of NIST and other frameworks?
Yeah, sure. So once again, Sensinet, along with a number of other organizations, is sponsoring a healthcare cybersecurity benchmark study, which is actually live as we speak. New this year, we're updating the NIST CSF questionnaire for version 2.0, as well as adding assessment for the new CPGs. We've also added a lot of automation into the benchmark to jumpstart the CPG assessment. Another new assessment, which I think is really timely, is assessing against the new NIST artificial intelligence risk management framework, which organizations could use to evaluate their secure and ethical implementation and use of artificial intelligence. As with last year, it's something that's open to everybody. It provides a wealth of information. It really, it helps organizations strengthen their risk posture and really see where they are in comparison to other organizations.
And it's co-sponsored with the American Hospital Association. John, what's your plug for providers? It's a no-cost option for them. How do we get more folks to go through this? It's a great benefit for everybody.
It is a great benefit. And Ed, we're going to continue to work with you and your team to promote this. It not only benefits the individual organization, you have peer benchmarking in here as well. It helps inform the sector. It helps guide national policy and advocacy on your behalf, on the hospital field behalf. It helps us understand what the potential threat vectors are, the vulnerabilities which still exist. So folks, please complete this. It will benefit not only you, but the entire sector.
And Jigar and Eric, you've both been participants in the past. Any advice to folks that are on the fence in terms of participation?
I think it is super valuable to not only evaluate yourself against the frameworks, but more importantly, get the benchmark data of your peer groups and the other folks in the industry, so you can see how far along you are against these frameworks and whatnot. So I think it's super critical. It's very informative, and it's a really good way to kind of figure out where you are and maybe help guide your strategy going forward a little bit. If you feel like you're behind in areas, and then you can focus maybe some efforts around those areas, in the future 12 months.
Mm-hmm. Eric?
I would just say you can take this stuff back, especially the benchmarking side of like the financial, the staffing, and so forth. And as Jigar was saying, what a great way. You always get to ask the question as a CISO, how do we compare to everybody else? And there's two things I answer to that. One is here's the answer, sort of like scoping and so forth. One of the things that this study does, which other studies do not do, is it gets the closest to normalizing what is actually a cybersecurity program versus anything else. Because not every cybersecurity program is the same. Jigar and I do not run the exact same program. We don't have the exact same functions that are on our teams. Like maybe he's got firewalls and I don't. I actually have firewalls, but or maybe Active Directory is run or not. Like those kinds of things. And the costs and the staffing and everything associated to that will differ. So you can't just take like bottom line cost center and then throw that out there and assume that it's apples to apples. So this study gets you closer to apples, which is great. The second thing I say is in an industry that is getting hit over and over and over again and has so much impact, regression to the mean is not the solution. So if you see that you're at 50th percentile, that's not like yay, like that's great. That should give you should shoot for more, like shoot for better on this and work with your executive leadership on like what is the right level of risk tolerance for your org based on your financials on what you need to be.
Excellent. John, we've got a question here from the audience about third-party risk, and I know you've got an interesting take on this, especially as it relates to the OCR data. Why is third-party risk such a serious concern, yet most businesses hesitate to allocate the necessary resources to manage it effectively?
Well, I think it comes to an understanding at the level of risk that we're exposed to by third parties. You mentioned the OCR data. So I've testified to this data before Congress. In 2023, about 80% of all the data breach attacks were attributed to third parties. You see the same trend for 2024. And of course, third parties getting hit with ransomware attack. So I think we as an industry had relegated third-party risk management to legal or compliance without sufficient really multidisciplinary input into that process. And really thinking about in terms of these life-critical and mission-critical systems. And and thinking about what would be the impact if certain technology provided by third parties failed. And I think we were too siloed in that approach to third-party risk management. So we need to take a strategic, multidisciplinary, risk-based approach to third-party risk management these days.
Excellent. Jigar or Eric, anything to add there? I know you both have pretty robust programs.
I mean, the only thing I would say is, as you're evaluating risk to your organization, materiality we already talked about. How material is the relationship? That needs to be a major factor. But the data they have is, of course, a major factor. How they're connected to you. You can have a vendor who is not material, has none of your data, but is connected to you in an incredibly risky way, and that will be how it happens. So it's those three lenses that are actually critical. And looking at how that happens to you. And then you need to be thinking also how you're inducing this risk to other people. Like, what are you pushing as the service provider now to somebody else? Because there is no organization, there is no hospital, there is no third-party services company that only has a one-way connection. And so you got to have that lens, that mindset in play. And then I personally want to get out of this everybody's asking questions of everybody else, and everybody thinks that they need to ask the question to everybody else, because it doesn't scale. What we need is the ability for us to understand our ecosystem, for the ability for us to understand the impacts associated with that ecosystem, and then some kind of continuous monitoring of that, of the basics things. Because as we said, the basics is how we get hit. Mm-hmm. That's the probable. So how do we get to a better understanding of how the ecosystem is healthy, and then how that ecosystem is connected to you so you can make a risk management decision? I think that is the future of third-party risk. Not to suggest that we shouldn't be asking all these questions. When it's material, you should. When it's not material, why are we wasting our time?
Yeah, well said. And as we think about that lens, it's also important to think about those controls and those tools we have to remediate risk. Obviously, one of those comes in from the audience here. They're asking about insurance. What are you hearing in the market or amongst colleagues about how cyber insurance is or is not covering losses? And so as we think about response and recovery in particular, is insurance getting tighter? Is insurance getting more intelligent about what to cover and what not to cover, given the data sets? Jigar, what are you finding?
So absolutely, right? So the premiums are going up because they're covering lots of losses. One, two, the deductible or the premium level is also going up. And more importantly, three, the services that you once saw were included 5 years ago. Now there's carve-outs and limits, et cetera, on the coverage points going forward. So the market has significantly changed. I'm sure that's been mainly due to the losses they've had to pay out over the last 5 or 6 years, and this market is going to continually evolve. They ask a lot of the same questions that we ask of third-party in the third-party questionnaire, and they're getting much more sophisticated in the questions they're asking. But at the end of the day, they're making a actuarial decision about you and your organization, and with the data that they have and that data point that they're using, the benchmark data they use for others is changing, and it's becoming more stringent.
Excellent. And John, you talked about clinical continuity earlier. Share with us, again, some insight and some recommendations for folks that really have no idea where to start around clinical continuity.
So again, fortunately and unfortunately, we've had a lot of experience dealing with victims the last several years, really speaking to them during, post-attack, conducting these case studies. And many of the victims are very shocked and surprised at how much they depended on network and internet-connected technology for these patient functions. So when we look at these vast, complex network diagrams and applications, and folks are trying to sort that out, we say, let's back up a little. Let's ask some basic strategic questions. In the context of losing your network and or losing your internet connection, understand function by function, department by department, and on a system level, literally these three questions: what will work, what won't work, and what's the plan? What's the plan to carry on safe and quality care in business operations for 30 days or longer? Now, I know these are easy questions to answer, but immensely difficult to answer. But thinking in this strategic mindset, literally having those individuals, those folks that are on the front lines, understanding and explaining how they use technology in their daily function, and start to plan. We're working directly with the Joint Commission to help develop guidance and services for clinical continuity, to develop for life-critical services and supply chain technology for 30 days or longer. Recommendations, not requirements. So that's the mindset we have to think about right now.
Excellent. And Jigar, is this something you have in place today, or something you're working towards?
So this is something I think no one probably has in place. Everyone has bits and pieces in place and are working through it. With every event, we continue to reevaluate the processes, and more importantly, we have to practice the processes. You know, the CrowdStrike incident forced us to practice in real time. We did learn a lot out of it, and we're going to take that back and reevaluate our plans. But every incident, you know, allows an opportunity not only to learn, but reevaluate and reassess so that we can be better, more efficient going forward.
The question came in: are there ways to test either tools or processes that an organization can use to determine risks such as these, to deal with continuity?
So one thing I would say to that is head over to the healthsectorcouncil.org website. We have built several toolkits on two, actually. One is related to what do you do within the first 24 hours of a large scale, highly disruptive attack. If you haven't done anything, it's kind of like a stand up. And then the second one is there's a template for effectively large scale response. How does this ultimately work? You're going to need way more than just that, by the way. This is not just a document that you build and put names on a document and you call it done. But it's a place to get you going. And I think that would be a very good tool. I like what John was talking about. I really love John's points, the three things to ask, because what that will get you is when you get to three, what's the plan? When you set it a goal, you set an objective, 30 days recovery, during this time frame, with what level of decompression is gonna occur. That will get people thinking about how to solution for that, versus the first phase of grief, which is denial. And there's no way this is gonna happen. On the five. And a big piece of this is actually getting people past denial. Honestly, they're even in this case, even after Change Healthcare, everybody still doesn't believe it's going to happen to them, or they think they can put it off. And you really can't. And so you got to get into the depths of this. And Jigar's right. No one has this right yet. There's at Intermountain, we've done 14 tabletop exercises this year alone because of how critical this is. But I'm not anywhere comfortable thinking that this is, we're ready. We're ready to hit the mark on the timeframes that we've set forth. There's always continual work on this. There will always be continual improvement. This is never a set it and you're done kind of situation. Excellent.
It's a great place to end. Let me first thank the panelists for joining us today. Thank you, Eric, John, Jigar, and Dave. Your insight, obviously, and your experience was extremely valuable. Thanks to the audience that participated and the questions. We had a lot that we didn't answer. We'll try to get to answers after the fact, and I would turn it over to the Beckers folks and thank them as well for putting this on.
Yes, I want to extend one more thank you to Ed, John, Eric, Jigar, and Dave for their insights, and Sensinet for sponsoring today's webinar. And a big thank you to our attendees for joining us today. I hope you enjoyed the rest of your day, and we look forward to having you join us for future webinars.